On behalf of the Provider Relations team at the University of Iowa Hospitals and Clinics, we thank you for attending today's presentation about urogynecology at the UIHC with Dr. Kimberly Keeney, urogynecologist, and Dr. Joseph Kowalski, also urogynecologist. Our faculty's goal is to share information you can use about the latest therapies and techniques in medicine and to answer your questions about how to partner with us in the care of your patients. If you would like more information or to talk with our physicians following this presentation, please reach out to your provider relations liaison or directly to our physicians. These are informational presentations to enhance your clinical practices and to provide you with the most updated information we have. No CME credit is provided at this time. This program is being recorded and will be posted to our educational resources for referring physicians page. At this time, I'll turn it over to our physicians and they will start the presentation. Thanks for joining us.
Okay, good morning all. Thank you so much for joining us. As mentioned, my name is Dr. Kim Keeney and I'm joined today by my colleague, Dr. Joseph Kowalski. This morning we'll be providing an overview of our urogyn practice at UIHC and hopefully be able to answer some questions that you may have at the end. Here are the members of our team. Dr. Catherine Bradley is the head of our division and our fellowship training. Dr. Kowalski and myself are also pictured there. And we also have 3 wonderful nurse practitioners who help us care for patients at our many clinical spaces. Here's a list of the clinical spaces in which we see patients. We have appointments available at 4 sites. 2 of those sites are in Iowa City, one at the University Hospital and one at Iowa River Landing. We see patients in Cedar Rapids every other Thursday. And we also have a site in the Quad Cities where Dr. Kowalski and myself see patients on Wednesdays and Fridays. However, to answer the question that many patients have, all of our procedures and inpatient care takes place at the University Hospital. As many of you likely know, urogynecology is a subspecialty of either OBGYN or urology. We focus on the care of women with pelvic floor disorders. And while this is not an exhaustive list, the majority of our patients and our practice is comprised of women who suffer from either urinary incontinence, pelvic organ prolapse, recurrent urinary tract infections, hematuria, fecal incontinence, fistulas, or obstetric or postpartum wound complications. Often our patients will have a combination of these disorders. It's important to note that many patients suffer from pelvic floor disorders, and despite the impact these disorders have on a woman's quality of life, our patients are often hesitant to discuss these problems with providers, and therefore it's our responsibility really to ask patients about these problems and provide care accordingly. And now a little more about each of these. So urinary incontinence is a common problem among women. It often goes underdiagnosed and treated. Studies have found that both the prevalence as well as the severity of incontinence increases with age. And it's estimated that around 25% of young women experience incontinence. This increases to about half of middle-aged women and up to about 75% of our elderly population. The impact of urinary incontinence is costly from both a financial as well as quality of life standpoint. There are several types of incontinence that we help manage, and those are listed here. Perhaps the most important part of evaluating patients for urinary incontinence is simply making sure that they're being screened for incontinence, as really less than half of women will seek care for this problem. Our evaluation for patients includes a basic history and physical, and then when indicated, specialty testing such as urodynamics or cystoscopy. Treatment options for urinary incontinence range from conservative measures to surgical interventions and really are directed towards a patient's goals. While some treatments for incontinence are useful for more than one type of incontinence, generally our management is targeted to the specific type of incontinence our patient is bothered by. Here are the therapies that we can help patients with at the University of Iowa. And like I mentioned before, it goes really all the way from conservative things to surgical interventions. We provide counseling on lifestyle modifications, There's the option for strengthening of the pelvic floor muscles, and that can either be done independently or with the guidance of pelvic floor physical therapy. We offer assistance with vaginal inserts. These are either over-the-counter and disposable, or a reusable option like a pessary. There's pharmacotherapy available for the management of incontinence. We offer both mesh and non-mesh procedures for stress incontinence, posterior tibial nerve stimulation, intradetrusor Botox injections, and sacral neuromodulation, most recently, which is rechargeable as well as MRI compatible. Now to shift gears just a bit, prolapse, which is defined as the descent of one or more aspects of the vagina, is also something that we help manage. It's generally described based on the component of the vagina that's protruding. So either the anterior wall, the posterior wall, or the apex or top of the vagina. This can be either the uterus and cervix or the vaginal cuff. It's important to note that some degree of descent is likely normal, and thus prolapse is only a problem or considered problematic if the patient has symptoms. The most common symptoms typically include pressure, the presence of a bulge, and that can be seeing or feeling it, change in bowel or bladder function, as well as sexual function. Again, treatment options for the management of prolapse range from expectant to surgical management, with several options in between. And as with urinary incontinence, our treatment course is really directed at the patient's degree of bother and their goals. Specifically, with regards to surgeries offered at the university, we offer a full breadth of options for the repair of prolapse. Generally speaking, surgery can be either reconstructive or obliterative in nature. The route can be either vaginal or abdominal. If the procedure is done abdominally, it's typically completed via a minimally invasive approach, and this is either traditional laparoscopy or with robotic assistance. Surgery can be accomplished with either a native tissue repair or the augmentation and use of a graft material. Surgery often involves the completion of a hysterectomy. However, hysteropexy is an option available to patients pending their unique situation. And now to switch gears a bit, I want to talk briefly about two topics I'm sure several of you have helped manage. So recurrent urinary tract infections and then microscopic hematuria. The definition of recurrent urinary tract infections is 2 culture-proven episodes in 6 months or 3 in a year. And it's important to note that these must be separate infections rather than a relapse of the same uropathogen. So certainly part of the challenge of managing these patients is tracking their culture results, the pathogen susceptibilities, and the treatments that they've received. It's really important that we let culture results guide our treatment for these patients, which can often be challenging as patients present to many locations when they're acutely symptomatic. Generally speaking, as I mentioned, antimicrobial agents are tailored towards the patient's culture sensitivities, obviously cost and allergies, and renal function. Some of our first-line treatments and second-line treatments are listed there. Treatment can be prescribed or self-administered, but again, preferable that it happens after a culture is obtained. And really, consideration for preventative measures should be offered if patients meet the criteria for recurrent infections. This can either be a prophylactic antibiotic dose or possibly the use of vaginal estrogen in postmenopausal patients. As you can see, antibiotic recommendations change slightly if there are complicating factors that we need to consider for that patient. So I think the question often comes up of when to refer these patients with recurrent urinary tract infections, as obviously this is something that can fall under many care or practice setups. For us, we really feel that this is appropriate at any time pending the provider's comfort. Certainly if there are abnormalities during the history or physical exam, if the patient has had a prior history of pelvic surgery, it's always appropriate to refer them, or if the patient is not improving with the care that they're receiving. And finally, for me, just a few slides about microscopic hematuria, which as a result, I'm sure several of you have seen or see on a regular basis. The definition of microscopic hematuria is a single positive, properly collected urine specimen with 3 or more red blood cells per high power field. And it's important that this is on urine microscopy, not a urinalysis or urine dipstick. Hematuria can be a sign of urinary tract malignancy, which is actually quite rare among women with a prevalence of around 0.3%. The recommended evaluation for hematuria is cystoscopy and a form of upper tract imaging. Most recently, a committee opinion released by both AUGS and ACOG advocated for sex-specific evaluation and guidelines when it comes to asymptomatic microscopic hematuria, given really that the prevalence of malignancy in women tends to be quite low. In this committee opinion, it was stated that the strongest predictors of urologic cancers in women are age older than 60, a history of tobacco use, or gross hematuria, and that in low risk, never smoking women younger than 50 years without gross hematuria and fewer than 25 RBCs per high power field, the risk of malignancy is less than or equal to 0.5%. So the recommendation was made that asymptomatic, low risk, never smoking women that are age 35 to 50 need evaluation only if they have more than 25 RBCs per high power field. This is a guideline that I anticipate continued updates on as well. And now I'd like to turn things over to my colleague, Dr. Kowalski, to talk about a couple of other problems that we help manage.
Thanks, Kim. So first, I wanted to touch on fecal incontinence. So the definition of fecal incontinence is recurrent, involuntary loss of solid or liquid stool or mucus from the rectum. The prevalence of this certainly increases with age. The prevalence numbers on fecal incontinence we know are probably underreported, as it's something that most adults understandably don't feel comfortable bringing up with their healthcare providers. So as Kim mentioned, with urinary incontinence, probably even more important for fecal incontinence is to screen for this, especially in the patients who are at most high risk, which are those patients who reside in nursing homes or other assisted care facilities. Fecal incontinence, of course, has just a profound impact on quality of life. It may even of itself be a reason for admission to a nursing home. Our typical evaluation, in addition, of course, to a history and physical, could include different things just depending on the individual patient. But these may be things like endo-anal ultrasound, anorectal manometry, defecography, or sometimes a dynamic MRI, which we have at the university, and bowel diaries. Similar to the other pelvic floor disorders that we manage, treatment options vary from very conservative to invasive procedures. And these would be biofeedback, medications, and other behavioral sorts of modifications. And then primarily the two procedures that we do for fecal incontinence are anal sphincteroplasty and sacral neuromodulation. And I highlighted sacral neuromodulation just because over the past 10 to 15 years, this really has become the standard of care for these patients, as opposed to anal sphincteroplasty, which we really do for fairly unique indications now. Next, talk about fistulas and also urethral diverticula. We manage all different types of fistulas, including genitourinary fistulas and rectovaginal fistulas. Genitourinary fistulas, of course, can come in many different types, such as vesicovaginal or ureterovaginal, urethrovaginal, and we manage them all. In general, these are managed surgically, though not always. For patients with significant comorbidities, they may be managed more conservatively. And the approach really is very individualized. There are, of course, as you know, numerous different procedures and approaches that can be used depending on the type of the fistula and the particular situation. You know, for example, if a patient had prior radiation or other surgical comorbidities may impact our treatment selection. Urethral diverticulums, I think, are important always to keep in the back of your mind when managing patients with pelvic floor disorders. You know, I think we're all kind of taught maybe in medical school and residency that there are the 3 Ds for urethral diverticulums: dysuria, dyspareunia, and discharge from the urethra. But in reality, those are not the most common symptoms with urethral diverticulums. And certainly having all 3 of those together is actually pretty uncommon. By far the most common symptom or diagnosis, if you will, that we see is recurrent UTI, followed by urinary incontinence. So, you know, I think for perhaps your UTI patients that may seem a little atypical, or you're just having a really hard time kind of getting a handle on their UTIs, this is always something to kind of keep in the back of your mind, especially because they're very challenging to diagnose on exam. Even in patients who you know they have a diverticulum from prior imaging, may really be hard to really appreciate that diverticulum on exam. MRI has become the gold standard for diagnosis. We do these here on a fairly regular basis. And then treatment, again, similar to fistulas, is generally surgical, though these can be monitored. For those patients who do elect to have them monitored, it is important to counsel them about the risk of adenocarcinoma in diverticulums. Although this is rare, it is something that we see. And so they would require monitoring on a regular basis. And for surgery, this is generally a vaginal approach surgery. And depending on their symptoms and prior surgical history, this can be done with an autologous fascial sling for the treatment of stress incontinence at the same time. And then finally, rectovaginal fistulas, thankfully, are something that we don't see all that frequently, but we most commonly see them after obstetrical injuries. Less commonly, you know, we may see them in patients with inflammatory bowel disease or other bowel disorders. And again, these are most commonly treated surgically. And really the last main topic that we wanted to touch on were postpartum wound complications. The incidence of these varies, of course, depending on the population that you're studying, but 3rd and 4th degree lacerations result from 4 to 11% of deliveries. And then so complications of those lacerations are less common, but they're some of the most challenging things I think that we as OBGYNs manage. And these can be rectovaginal fistula, immediate or delayed repair breakdowns, infection, anal incontinence, and then sometimes very complex cloaca-like defects that can result. You know, obviously these can be managed both medically and surgically, though I think in this kind of group of patients in particular, would really emphasize that they can benefit from expeditious referral. You know, we know that within the first few days after one of these complications, there is often the option for treating them quickly, even if that's surgical treatment, before kind of wound remodeling or infection can take hold. So, you know, we are always happy to see these patients same day, you know, if the provider has a concern we'll always fit them in. After that kind of 6 to 7 day mark after delivery, or if there's evidence of infection, generally treatment of these, at least surgically, needs to wait about 3 months. So again, the quicker that we can see these patients, if there are concerns, probably the better for the patient. Just to also add a plug for our physical therapy team, they are just fabulous. We have 4 full-time pelvic physical therapists, Carrie, Natalie, Katie, and Amy. They all currently have clinics at the main campus in Iowa City. When to refer, I think we touched on this a little, but I think the bottom line is whenever you feel the right time is. We are happy to see patients. Please never hesitate to reach out directly to any of us, especially for more complicated referrals. We are always happy to expedite any referrals and see your patients, when you and the patient feel the time is right. And why refer, other than, of course, the medical conditions that we talked about. The 3 of us are actually the only 3 fellowship trained and board certified FPMRS providers in the state of Iowa. We have multiple locations, again, including Iowa City, Coralville, Cedar Rapids, and Davenport. We have a whole team. We work very closely with our urologist and physical therapy colleagues, as well as our colorectal surgeons for our more complicated patients. Our treatment ranges everywhere from behavioral counseling to complex pelvic reconstructive surgery. So yeah, I think those are the best reasons.
Okay, so I think that concludes sort of the formal part of our presentation, and we're happy to take any questions that may have come up.
Doctor, can you tell me about the mesh used in the urogynecological procedures that you do? And as I know, there's been some recalls over the last couple of years of certain meshes.
Sure. So, so kind of just big picture, the synthetic mesh that's used in either incontinence or prolapse surgeries is a polypropylene mesh. So it is a permanent substance. And as many patients and providers have probably seen, there's a fair amount about mesh products in the media, and I think everybody's heard the various commercials for lawsuits, et cetera, involving mesh. So we do use mesh in the appropriate patients. The ways in which we use mesh are either for the treatment of stress urinary incontinence, and that would be in the form of a midurethral sling. That's either retropubic or transobturator. And then we do use mesh for the management of prolapse, but that's mesh placed abdominally. The mesh products that are no longer available or that have been sort of quote unquote recalled really are mesh products that were placed vaginally for the management of prolapse. And those are products that aren't available on the market anymore. And I would say products that I personally, and I think I can speak for my colleagues as well, never really used in our practice. And so when we talk about using mesh with patients, it's usually a conversation of risks and benefits, just like any form of treatment.
One other thing that I would add to that, Kim, is just that, as you mentioned, the decision for mesh is a decision between the patient and the provider. And for patients, who may have specific concerns about mesh, we do have some pretty good alternatives, including using their own tissue and autologous tissue grafts, for example, like rectus or fascia lata.
What information is useful for us to send with the referral?
Yeah, so, great question. I think certainly what your question is or what the patient's concern is useful. And then kind of the most up-to-date clinic notes or exam findings, if there's any imaging that has been done, that's always useful to have when we see the patient the first time. And then the other thing I'll mention is that for patients who have had prior procedures for the management of pelvic floor disorders or kind of urologic or bowel conditions, it's always wonderful if we can have operative notes just to have an idea of what has previously been done. The other thing that I'll mention, which is sometimes challenging to get, is if patients have kind of significant medical comorbidities that they're managed with kind of a local cardiologist or whether it's their internal medicine physician, if those records can come with, especially for patients that we might be considering surgical intervention for, we usually will make sure that they're, you know, kind of up to date and safe for surgery.
I'm really grateful that you have 4 outreach sites that you see patients at. And I know you did mention, though, any surgical cases do need to go up to the main campus of the university. Is that correct?
Correct, yeah. So, you know, we see patients really Tuesday through Friday at IRL. That's kind of our main clinical space in Coralville. We see ambulatory setting at the university. We're in Cedar Rapids every other Thursday and hopefully soon every Thursday. And then we're in the Quad Cities every Wednesday and Friday. As I mentioned, our surgeries and any inpatient care would happen at the main campus, but we certainly are happy to do, you know, both our sort of pre-procedure as well as follow-up care at those outreach sites. So we do try to minimize the amount of travel that patients will have to undertake.
Great, thank you.
We do have a few more questions. What can patients anticipate when they come for a consultation?
Sure. So we do have kind of a team-based approach. We are, you know, an academic medical center, and so it's not uncommon that we will have learners in the clinical space with us. That includes fellows who are training to be urogynecologists as well as obstetrics and gynecology residents. Occasionally we will have medical students with us. Patients can anticipate getting kind of a series of questionnaires, and these tend to be standardized questionnaires that we use to evaluate their symptoms, as well as kind of a review of their, you know, past medical, surgical, and OBGYN history. We do a pretty thorough history and physical exam, and then really specific counseling to why they are there. I would say most new patient encounters take around 45 minutes. And then we hope at the end of that encounter to have a plan about next steps.
Great. When is the best time to refer a postpartum wound complication?
I can touch on that. You know, I think, well, similar to other things, you know, whenever the provider and the patient think the time is right, but maybe more so than some of the other conditions that we treat, you know, as soon as possible usually is best for these conditions, mostly because there's certainly a chance that if they're referred soon enough within, you know, generally 2 to 3 days after the complication or after delivery, these may be able to be surgically fixed immediately. Because really the unfortunate problem for these patients is if they are not managed immediately before infection sets in or tissue remodeling really starts, and they're really kind of stuck with the problem for at least 3 months, you know, and these are, of course, the 3 months with a newborn. And so if these can get managed quickly and fixed right after delivery, that's best. Even waiting, you know, 5 to 6 days is pushing it a little bit. And then oftentimes we have to wait the full kind of 3 months before going back to fix the defect.
Are there any types of fistulas that you would suggest referring to someone other than a urogynecologist?
Sure. Primarily, some of the fistulas related to bowel, ones that are primarily bowel or GI and etiology. So, for example, sometimes we're referred fistulas that are the result of diverticulitis. These are generally going to be things that are best managed by a colorectal surgeon because they're often going to require a bowel resection in addition to the fistula repair. Other things may be fistulas related to Crohn's disease or ulcerative colitis, of course, colorectal cancer as well. In general, we would manage all genitourinary fistulas. Really can't think of any, other than perhaps a malignancy related that we would refer elsewhere.
One last question. When would you consider an anal sphincteroplasty versus the sacral neuromodulation for fecal incontinence?
Sure. Really kind of depends on many factors. One factor is the time from the anatomic insult, so which is usually delivery. If this is a patient with fecal incontinence onset decades from her last delivery, not always, but in general, we're going to be thinking more sacral neuromodulation than anal sphincteroplasty. Things that may make us think of an anal sphincteroplasty, I think primarily are when the patient has other symptoms than just fecal incontinence that may be related to that anatomic sphincter defect. So for example, sometimes with these defects, the perineal body becomes very small, almost non-existent, in which case some people have a very difficult time even with just simple day-to-day hygiene because there's just really no space between the vagina, the urethra, and the anus. So I just use this as one example, but that may be a case where we could potentially make an impact on the fecal incontinence, but also kind of an anatomic reconstruction as well that would help some of their other symptoms.
Great, thank you. So that looks like it's the end of the questions. We really appreciate you guys presenting this morning. I think this was fantastic information for everybody. And for anybody who has interest in talking with Dr. Keeney or Dr. Kowalski, you can reach out to them directly, or you can also reach out to your provider relations liaison. We will be distributing this information, so our contact information is there. And other than that, we really appreciate you guys presenting this morning, and thank you.
Of course, thank you very much for tuning in.